We're in UL, back where it all started. Nice evening, lovely evening. There's no sun out, but there's no rain either, so we'll take it. Nice and dry in the lovely Limerick.
Hopefully you can hear us okay. There shouldn't be too much background noise.
No, do you want to kick it off? We get started?
Yeah, I guess we can't start the show today without saying a massive congratulations to Kat and Brian. We had a great day yesterday with them down in Tipperary as she became Kat Reid. So a huge shout out to Kat and Brian for an amazing day.
Class day, class venue.
Yeah,
Jesus.
it was brilliant.
And everyone was looking stunning.
I'm sure the Maddens and Reeds are partying on now tonight, so a big shout out to them.
Enjoy it.
So we're going to start just the usual situation. If you haven't joined us before, it's the first time watching, hello. What we try to do is answer any questions, any physio related questions you have. So you can pop your question in the comment section, or alternatively, if you don't want us to mention any names whatsoever and you want to be anonymous, you can send us a private message. We have the phones here beside us. You can just send us a private message and we'll do our best to answer any questions that you have. So we're going to kick it off first of all with a few of the questions that we didn't get to last week. So hopefully those that asked those questions are tuning in. The first one, Ollie, let me just bring it back up again. Yeah. Very straightforward and a common one, I think. Hopefully everyone will find this beneficial. It was simply, the question was, could you explain more about bursitis, please?
And more specifically in
the hip. In the hip, yeah. So we got back to this person and asked them where the problem was, and they told it was in their hip. So bursitis is a really common complaint that we hear of in physio. And I think what we want to do is first of all sort of explain what it is and then sort of how we would manage it. I'll kick this off, will I? So the term bursitis is an interesting one, and over the last few years in the world of physio we've sort of moved away slightly from the diagnosis of bursitis. But when people come in and they have bursitis, generally what they're describing is pain on the outside of their hip. So this patient will come in saying it's very sore to touch the outside of their hip, and any pressure on their hip is painful. So this is the patient that can't lie on the hip. They'll be woken up at night if they lie on that side. This patient will often tell us that they start to get pain if they walk too far, or if they get caught standing in a queue, they'll start to get pain on the outside of the hip. We differentiate it from other types of hip pain because it usually is on the outside.
Definitely more lateral, yeah.
Yep. They don't have actually anything wrong with their hip joint, so this is not the patient with hip arthritis. Their hip joint is usually in good shape. They don't usually have groin or back pain associated with it. Now, it can travel down on the outside of the leg, but very rarely below the knee, so it would just be on the outside of the thigh.
Yeah, and if it does go below the knee, it just goes barely below, kind of on the lateral shin. It doesn't go all the way down to your foot. That's something else.
Yeah, again, we would be looking at sort of a different diagnosis for that. So these true bursitis or lateral hip pains, it will be mainly on the bony part on the outside of the hip, can travel down the leg, and as Ollie said, on the ones that are bad will present as sort of lateral knee pain as well a little bit, particularly if they've been walking or if they run and they've got lateral hip pain. So this term bursitis, well, really interestingly, some of the studies that looked actually at ultrasound and sonography of the outside of the hip to see what was going on, the bursa was getting blamed, but in a lot of cases it wasn't just the bursa causing the problem. So where this bursitis, where the pain comes from, is on the outside.
Reverse it back. What is a bursa? You're saying bursa, but
okay, let me describe. Yeah. So on the outside of our hip bone we have the ball of our hip, then there's a neck of our femur, and then there's a bony protuberance as the long shaft of the bone starts. We call it a trochanter.
Yeah, normally you can feel it just around kind of where your pocket finishes. You that bony bit, that's not the actual joint, that's the bone on the outside. The actual ball is located right in around, deep in around your groin area. So we're talking about the area around the outside of your pocket.
Yeah. So on that bony part, it's a real big area where different muscles attach. So a lot of your glute muscles, which are the big muscles that move your hip, the deep muscles that rotate your hip, lots of their tendons, so the ends of them, attach into that bony part that Ollie's talking about on the outside of the hip. And then around that greater trochanter, you don't just have one, you have loads of little things called bursas. And a bursa is basically a little fluid-filled pouch. And its purpose is to allow the tendons to glide and slide and move comfortably when we move our hip. So they're filled with something called synovial fluid. So little membrane sacs filled with fluid.
Like little cushions, basically, shock absorbers, kind of in between the tendons.
So what then goes wrong with this bursitis? Well, what these images have shown that it's not just the bursa causing the problem, and in fact we're starting to think now that the bursa is a symptom of a problem that actually is to do with the tendons. So we're now starting to think of this bursitis problem as being more related to the little areas of white tissue where the muscle attaches to the bone, where our glute muscles attach, mainly glute med, glute min, a bit of piriformis, where that little white tendon tissue, in these patients who are having problems, those tissues have tiny little tears, and they're actually thinking that that's where a lot of the pain is coming from. And then that is irritating the bursa. So they're finding less and less inflammation within these bursas, and that they're thinking the pain now is more to do with tendon than it is to do with bursa. And also sometimes there's an element of, there's a deep layer of fascia that runs down the outside of the leg called our iliotibial band. And they're finding that part of the iliotibial band can be irritated where it comes from that bony protuberance on the outside of the hip. So I guess what I'm saying here is that we probably think now that bursitis isn't just bursitis, and that it's actually now greater.
It's more of a symptom.
Yeah,
than
it's
anything.
a symptom.
It's a symptom of the overall condition.
Yeah, and we're tending to call it now a sort of greater trochanteric pain syndrome. So that bony part is the trochanter, and then the syndrome part is that it's not just the bursa, that the tendon is involved as well. So that sort of explains what we think is going on.
So what do we do about it?
Well,
what can someone do?
What can we do about it?
What can someone do about it if they have it?
So if somebody has it and they're having pain lying on that side, walking, standing, what happens when you walk or stand is that you contract your glute muscle to keep your pelvis level, and then the tendon pulls on that little bone on the outside, and that causes pain.
Mm-hmm.
So the first thing that we would say for those, sorry, we've been in the background, first thing we would say is that try to stop the compressive force on that lateral hip. So if you're getting pain when you lie on that side, the first thing that we would recommend is try to avoid lying on that side, or positions where there's pressure on the outside of the hip.
Okay. Well, you say lying on the opposite side, so you're lying on your good side, but what I also see is that once the knee starts to come past the midline, so if they're lying on their good side, and the top leg and the knee starts to drop down, that can also just pull at the tendons.
That is true.
So the best thing to do there would be to pop a pillow, or even two pillows, in between the knees to keep the knees open as you're lying on your side, and that just offloads that tendon and makes it a bit more comfortable for you to sleep on. Good, so they can offload it.
Offload it, yeah. The second thing that we are now managing these bursitis with, so conservative management, we should say, is what we're talking about here. Conservative management is the forced protocol, which is offloading it. Patients then can get short-term symptom relief from either ice or heat over the bursa. Now, that's not doing anything more than just deadening the pain short-term, but it is an option to try and manage the symptoms. And then in our conservative management, we focus on trying to restructure that tendon, and that involves strengthening exercises of mainly the glutes and the hip rotators. So any of our patients that come in with this greater trochanteric pain syndrome, I try to find an exercise that they can tolerate that exercises their glutes. Would you agree, Ollie?
Absolutely. Keep loading, trying to gradually load the glutes.
Yeah.
Start off nice and easy.
Yeah, I usually start really, really simple, like our clam exercise. If you Google clam, you'll see what I'm talking about. That's a really good one because it works your glutes and your hip rotators, and that tends to be the bit of the tendon that's most irritated with bursitis. Now, some patients can't even start there, and like always, our advice is if you're in any doubt, you get it checked out with your healthcare provider and they'll guide you. But generally, you would start with a simple clam.
If you can tolerate it.
If you can tolerate it, progressing it onto side leg lifts. There's some nice ones that you can do in standing too. And if standing is a problem, often I'll get my patients to just practice standing on one leg, seeing how long they can tolerate that without pain.
On the bad leg?
On the bad leg. on the bad leg, and then grade that up to see how they go. And again, that's just a strengthening exercise to load the tendon. So conservative management is really focused about trying to restructure and strengthen up that tendon.
How long would it take to restructure the tendon?
No,
so
this is
loading?
the problem. You have to be patient. Like, this does not change overnight. You know, you're really talking about committing to a plan that's probably, you want to see them responding within the 6-week window, but really these patients need to commit to their exercise program for 12 weeks up to 6 months to really get on top of it long term.
When you say responding within 6 weeks,
start to see an improvement.
In symptoms.
Yeah.
Okay.
What do you think?
Absolutely, I completely agree.
Yeah.
It's a long road with this problem.
Yeah.
You can't restructure, reorganize tendons and muscles overnight, but if you stick with it, all the studies show that there's really, really good evidence to say that strengthening up that hip can help recorrect that imbalance and offload it to make it, well, not offload it, but to reload it properly. So
Yeah.
that
Just to
not
be
painful.
just to be clear on that, we, like, in terms of contact with physio, this is one of those things. It's not a weekly event either. With these patients that come in, if they're very irritable at the start, we might see them a few times to begin with to make sure that their exercise is comfortable, but then we'll send them off with their strengthening program to work on it for 3 to 4 weeks, then come back to us, and then we'll progress it and we push them on again. So really finding the exercises that you can tolerate are key. If it doesn't work, like what, because I know loads of patients that have had injections for their bursitis, like what do we feel about having injections for it?
So yeah, there's good evidence to show. We've had a few questions in.
Yeah,
We'll go through it in a second. So there's good evidence to show that the injections can really help and can really work. Normally they can do up to about 3 injections.
Yeah.
They don't like doing a whole lot more than 3 because there's risks obviously involved with the injection. It can weaken the actual overall structure of the tendon, which is not good for it, but it can really help to settle that acute inflammation, acute pain down, to allow you to engage in your conservative rehab. I have had some patients that have had the injections and didn't engage in any conservative management, and then what happened was the pain initially settled for a few weeks, and then after a period of time, once the injection wore off, pain came straight back again. So what we did was we started them off in their graded exercise and then sent them back for the injection or for another injection, and when they came back then we kept going with their exercises, and they got really good outcomes. But there's also another thing to point out is that it's not just the hip that sometimes causes the pain. Sometimes we have to look above or below the joint, so sometimes we look all the way down to the foot, because sometimes the feet, if you've got quite flat feet and you're collapsing in when you walk, that can also cause load up on the hip, and equally the hip can sometimes cause people to get things like plantar fasciitis that we spoke about last week and things. So that's probably one of the
I just want to say about the injections that it definitely, from a research viewpoint, like the injections do give short-term relief, but when you compare, shockwave therapy is another thing that people have done with bursitis, but in the studies when you compare injections, shockwave therapy and conservative management exercise, at 6 weeks the injections look like they're best, but actually long term, over a 15-month period, it's the people that engage with the conservative management that improve long term. And another point about the injections is that the guided ones work better, and if somebody isn't getting any relief, if they're doing their conservative management and we're getting nowhere and we're looking for something else to try and help us, we would try and get a guided injection where we can. That's where they're using imaging to see where the actual steroid is going into.
But as a rule of thumb, they would normally do the first one or second one unguided, so they would just stick it in and see how it works.
And it is worth a shot.
It is, literally. But
literally worth a shot.
So there was another question as well that we got last week. Then was
hopefully that clears up anything about bursitis, which we call greater trochanteric pain syndrome, and it is worth googling that term because you can get good tips and advice from that. We do want to address the other question from last week.
A question asking about someone that has a labral tear, again dealing with the hip joint. So they have a labral tear and they're just wanting to know, is there anything that they could do exercise wise and stretches wise for that, to alleviate some of the pain that they have.
Yeah, let me just bring the question up. I think it was that they were swimming. Any ideas on exercise I can do to ease the pain of a torn labral joint? I love swimming, had to stop, the pain was too intense when I got out of the pool. Any advice? will be appreciated. So maybe just what is a labral tear first of all, just for people that might not know.
So a labral is basically cartilage, alright, so it's a form of cartilage, and a labral, or labrum, actually give it its proper term, so basically we've got the cup in the hip and we've got the ball that sits in the cup. Now if we look, so take the ball out for a second, if we look at the cup, what we have is we've got an extra rim basically that runs right around, not all the way, but runs mostly around the edge of that hip, acetabulum, sorry, give it its proper term. So it runs all the way around, and that basically what it does is it deepens the socket for the ball to sit in. So that's pretty much what a labrum is.
Yeah, it's an extra flap of support around the hip, probably a bit like the texture of your ear, that type of material, and it tears.
So how does it go wrong? What happens for it to go wrong?
I guess the first thing to note is that labral tears are extremely common, even in asymptomatic hips. So I guess in that sense it's probably a bit of a wearing part. Like over the years you'll get tears in it for different reasons, and sometimes it's no problem whatsoever. So that's important to note first of all. It can go wrong for a few reasons. The main reason, so it can go wrong if you've had a trauma to the hip, or if somebody maybe had hip dysplasia when they were a kid, then they can have problems with their labrum, or if they were involved in a car crash where they got hit in their knee and their hip got jammed into them. That can obviously cause traumatic problems. But the most common reason in non-traumatic or in non-dysplastic hips for a labral tear is due to a change in shape of the femoral head. Something that we call a cam deformity, if you want to have a Google of it. It's where instead of having a nice round top to your femur, you end up with like a little bit of extra bone that grows on your femur. We're not too sure why this happens, but an interesting statistic in a systematic review of elite athletes, 67% of them, asymptomatic, had these increased growth on the top of their bone. So we're not sure that if it's to do with the stresses that you put on your hip while you're growing and developing, or we do see them in our GAA players. They definitely are having these bony changes if they've been playing from a young age. But whatever happens,
it's not necessarily a bad thing though, because
exactly,
you said it's asymptomatic.
Exactly.
A lot of people have this and they're absolutely
and
no
they're
problem.
fine. But for some reason, in some people, what happens is the extra bone on the femur starts to butt against that labrum.
It's grating against it.
Exactly,
yeah.
and it causes tears to the labrum.
Good. All right, so that's a tear. So what can this person do with their tear? So
Okay.
they mentioned swimming. So first of all, I would probably break it down and look at the stroke that you're doing in swimming. So one of the most aggravating movements for that tear in that labrum would be the rotation of the hip. So in swimming, that would be your breaststroke. So where you're kicking the legs right out around, and basically what you're doing is you're bringing the ball into the socket, and you're moving it right around the rim as you rotate. So that's certainly going to irritate it. You might get away with doing some forward and back movements in terms of your front crawl or your back crawl. So that would be a way to start there. If you can do that, perfect. If you can't, then you're going to need to step it back a little bit more and try and do a bit of work firsthand.
But water, like the pool, you're onto something in the water. My most irritable labral tears that we're really struggling with, even getting in and out of the car, clutching, I get them in the water and do strength-based exercises with them in the water that are relatively pain-free. So we're talking about things like sidestepping in the water, lifting the leg out to the side and back down, working an extension, lifting the leg out behind and back down, doing little squats, not full range because when you go past 90 it can be irritable, but we would look at a strengthening program in the water for those that are most irritable. It really does take the pressure
water as they get stronger.
Exactly.
So you can build up the strength around the hip to really try and help offload that labrum as much as you can. And what can also occur is, again, I use my fist. I haven't got a model, so using the ball, sometimes what can happen is we can get really, really tight around the muscles around the front of the hip. So if you can imagine we've got the ball centered in the joint, what can happen if we've got muscles attached to the front of that leg, if they become tight, the ball starts to move forward towards the joint. So when we're going into our flexion, so when you're sitting down or you're going into your deep squatting positions, the ball is more likely to engage with that labrum as you bring that leg up. So what we would look to try and do is maybe do some stretching to try and offload the muscles on the front of the hip. We would also...
What position would those stretches be in? Because some of the stretches
So
we
you
have to
could,
be careful with?
so you could try lunging. You know that hip flexor stretch in lunging where you're coming down. If that's too irritable, you can sometimes do it with a chair. So you can Google it and look up the images on Google, or you can go to your health professional. But you can pop your leg, so your affected leg, on the chair, and then you're pretty much just kneeling on that, and then just leaning a little bit forward until you feel a little bit of a pull or stretch. I don't want you to push through pain, so you get a little bit of a pull or stretch on the front of the leg. If that's too irritable, then lying on your side and doing your kind of quad stretch
again,
where you're starting to pull that knee back a little bit as well, so you're engaging a little bit of the hip flexor as well. But if they're too irritable, then
you really need to check in with your healthcare professional to figure it out, because a lot of patients that have underlying labral tears that might not know feel that the hip is tight, and they keep trying to do this knee to the chest stretch, and actually because it's a bony change, all you're doing is jamming bone up on bone, and you're wondering, why does it feel so tight? And actually that is completely pointless, doing that with someone who's got a labral tear. You're just annoying the labrum. So it's opening that hip up in terms of stretching, and then trying to find comfortable strengthening exercises. Again, if in doubt, you get it checked out. There's one here, Ollie, actually, that I think is interesting. So just getting to some of the other questions that are coming in. Hey guys, got my left ACL operated on 2 years ago. Was with yous for physio, good. But of course, after I went back to work, I stopped going. Not good. Knee gets tired easy. Is there anything I need to do, or just back to physio? Really want to play sport again.
So
Ollie's the ACL king, so he's going to answer this.
So after your ACL, so what is your ACL? Your ACL is a ligament, basically. You often hear it with the soccer players. It's a ligament inside in your knee joint. We've got 4 ligaments in the knee joint, but it's probably one of the most common ones that we would see that get ruptured.
Yeah, it's a horrible injury,
kind of a
unfortunately.
twisting and a forward movement. So in terms of after you get the operation, you really need to engage in a prolonged stint of rehab to really strengthen the muscles around the knee, improve what we call your proprioception. So that's your awareness of where your knee is.
Question here, Ollie. This person has done their post-op physio, right, which lots of people engage in really well. They get their knee to a good function so they can do what they need to do.
In terms of work.
But you are not alone. So many people then drop off their rehab and they never get back to the sport that they want to do. Like, it's so common after ACL, because what is required to get that knee back is it's hard work.
6 to 9 months, really. So
it's 6 to 9 months of constant work on that knee. And it's gym work, it's strength work, it's committing to doing your sessions 4 times a week to try and get it as close to the other leg as possible. And so what does he need to do here in order to get back to playing sport?
You need to engage in an actual graded program. I would say you probably need to come back to or go to a physio. Doesn't necessarily have to be us.
Preferably us.
But so it's going to have to be a graded program to get back to it, and it's going to be looking at where you are based on your strength and your deficits, and then progressing it from there. But even trying, if you've only maybe done 2 months, 3 months rehab, often what you haven't done is you haven't sufficiently loaded the actual new ligament that they've put in. And then what happens is that's not sufficiently strong enough, so that remodels with all the stress and the load that we put on it over that kind of 6 months to 9 month period. So what we would often see is, again, people mightn't necessarily do their whole rehab, go back to sport too soon, and end up tearing it again.
So we would definitely recommend checking in with your healthcare professional before going back to any sport if you haven't been doing your program.
And again, it's not a case of having physio weekly or anything.
No,
it will be a case of
gym work.
doing up a decent program for you, sending you off for a few weeks, getting you to come back, reviewing your progress, and then going away again, and then being able to gradually grade you back into kind of your more sporting activities in terms of change of direction work, sprinting, running, agility work and things, while you're still maintaining your strength work. So definitely need to, if you want to get back playing sport, as you said, you probably have enough strength after 2 to 3 months to go back to your normal kind of your work and activities that you do throughout the day. But if you want to get back to sport, it is a hard slog, and there's probably only maybe 50-60% that we would see
it's
really
real
do
commitment.
put in the effort to get back. So it's tough, but
when
if
you
you want to get back,
when you rupture your ACL, you really get to know your physio well, because you're with them for quite a while. You might see them before you have your surgery, and then a year later, if you're really committed to getting back to your sport, you're still checking in with them weekly. I would say the goal is to get your strength within 80% of the other leg?
Oh, more, 95%.
Well, there you
Strength,
go.
strength is definitely key, and you're looking to get, like, we measure things like single leg hop. So if you can hop, so you could even try this at home and see how you get on with your hopping. So mark out a distance where you're going to hop with your other leg, unaffected leg, and do single leg hops. Hop 5 or 6 times to see how far you can get. Measure it, and then go with the affected side that you've had done. Now you should be within about 95% of that distance on your other leg. So if you're nowhere near that, you definitely need to be. You've got a lot of work to do. That's just one of the basic tests.
Yeah.
But, obviously
it just gives you an indicator of where you are with it. But I think the thing is, when you do put in the work, you absolutely can get there. And we rehab these ACLs all the time back to support successfully. It's just, you're a perfect example. Once you go back to work and things are doing pretty well, you struggle then to get the sessions done. So, and it's never too late. You can absolutely still get the work done now. So touch base with us and hopefully we can help.
Good. We've one more question. Well, a few more questions. We'll get to one more, I think, because what are we pushing? We're pushing 20 odd minutes now.
Okay, so this is a bit of a longer message, but I'll just give you the gist of it. This is an elderly lady, I'm not too sure what age, and having problems with pins and needles and numbness in both feet and legs, struggling to walk long distances, and there seems to be some pain in the back as well. This is gonna be tricky. I'll just make a few assumptions here which might be dangerous, but when we have
lady. It's not necessarily an elderly lady.
Well,
middle-aged,
we're not too sure. Let's just try and give the gist of what we think would be going on here. So if somebody comes into us with pins and needles and numbness, if it's in both legs, then usually there's one of two things going on. Either there's something going on from a spinal point of view, or there's something going on from a circulation point of view. So the first thing we would say is that it's essential to get to your doctor to rule out anything going on from a circulatory point of view, where they would check the pulses in your feet, check your cardiovascular status to make sure there's nothing actually stopping the blood flow getting down there. From a spinal viewpoint, we often see patients, and this is a classic presentation. They come in, and if they walk any distance, they'll start to get bilateral, so pins and needles and numbness in both legs. And these patients will love leaning forward on something. We can see them a mile away when we're out and about because they're leaning on a car, they love the shopping trolley. Anything that lets them lean forward gives them relief.
And you can see it, you can spot it, in the elderly population.
Generally elderly.
Really leaning
forward to get relief.
That's not because their spine is gone that way,
Nope.
It's just because they get relief and they don't get any symptoms. That's why they tend to lean forward quite a bit.
So what's going on here usually is so if we think about the structure of the nerves in our body, we have our brain at the top, and then out of the brain comes our spinal cord, and at each level of the spine we have big nerve roots that come out. And these nerve roots come out a pretty narrow space at each level of our spine. So we have bony blocks that make up our vertebrae in our back, and between each vertebrae there's a little gap for these nerves. As we get older and the normal changes that happen with age, unfortunately there is narrowing of the spaces around these nerves. And when we are upright or extend back, if we have age-related change in our spine, it can narrow the space between around the nerve. And that irritation of the nerve is what causes the pins and needles and the numbness. If you stand up or you walk, that increased pressure can increase the pins and needles. By leaning forward, you actually open up a little bit of space for these nerves, and it relieves the symptoms off.
I'm going to interject here and just put Kira on the spot. So would you say that's central canal stenosis, or would you go it's bilateral stenosis? So is that bilateral narrowing on each side that you suggest that this lady might have, or is it more central in around that actual spine where it can also narrow in around that spine?
Well, that would very much depend on symptoms, and this is why we would strongly encourage this particular lady with her question to get checked out by a healthcare professional, because having narrowing centrally in the spinal cord will come with other symptoms which will flag us up as a bit more of
any particular symptoms come off the top of your head?
I don't want to worry anybody or panic anybody, but there would be symptoms that our patients would tell us that we would then direct them towards your GP.
Loss of balance, maybe?
Yeah, where they're struggling to walk in a straight line. If they're struggling to cross the road, they find themselves drifting across the road. But again, if you're suffering from any of those symptoms, you need to report them to your GP. If this, you can't,
So what would
it
you
can
do?
happen both ways.
Yeah, so what would you do? Or what should they do?
I think first of all,
It
with
would
these
be-
patients, we get a clear diagnosis to make sure we know what's going on. So we would work with patients like this that have come through Physio. We work very closely with the GPs. We get them sent off usually for an X-ray first to see what the state of play is. If there is changes at the bottom of the spine, we'll then usually follow that up with a scan just to see how the nerves are doing. And then there's choices for these patients. Conservative management will probably try first. We generally try and give these patients opening exercises of their spine where we try and encourage, bending forward and getting them moving, mobility, so that the spine doesn't stiffen up. So we would start on an exercise prescription to open up the spine, but also to strengthen the muscles around the spine so that you can tolerate things like walking and loading activities a little bit
So
more.
trying to offload the nerves a little bit.
Offload it as best we can. If they fail, then with these patients we do communicate with our other healthcare professionals. We do get opinions of the orthopods or the neurologist to see if there's anything more they can bring, because sometimes they'll inject some analgesic or even epidurals for these patients to give them short-term relief. So if they're really struggling and they're losing their mobility, we will push it further to try and get some relief for these patients. So yeah, it's really uncomfortable. These patients are usually very frustrated. They end up sitting a lot because they're more comfortable in sitting. And then slowly but surely they start to lose their function over time. So I would recommend to this person to please go and touch base with your healthcare professional to see if we can get to the bottom, even with your doctor, to guide what we could do to help in this situation.
Yeah, if it comes down to just simple pacing as well, trying to break up your tasks and trying to walk short distances, sit down, rest, and then go again, as opposed to just not being active at all.
Okay, one really quick one because we're just over the half an hour mark. This one is a really tricky one, unfortunately. So this question is, what, if anything, would you recommend in treating costochondritis? Can't keep taking anti-inflammatory tablets, have been stretching, but it just keeps flaring up again.
That's a tough one.
It breaks our heart when people
It's
come in with
really tough.
costochondritis. It is really tough. So what is it, first of all? It's usually pain in where the ribs meet the cartilage of the ribs, so they usually come in with pain around the rib cage, pain on coughing, sneezing, twisting, turning, reaching, deep breathing. These patients really struggle, and this person is spot on. This is a cycle of flaring up, settling down, flaring up, settling down, and it can be really tricky to manage and takes an awful long time to get on top of. And your treatment options are really limited.
Yeah.
There's no, we don't inject for costochondritis, we don't operate on costochondritis. We try and manage it through stretching. We do some manual treatment on it, but to be honest, we find it's very short-term relief. We do work on the muscles of the rib cage to try and support the costo angles as much as we can. I often give thoracic-based stretching and strength work around the rib cage.
So when you say strength work, are you talking about core? Are you talking about deep breathing exercises? What are you talking about?
I
strength
normally
wise?
do
Just give them something tangible that they can actually.
I normally do
none of this wishy-washy stuff.
I normally do a combination. I think about the muscles that attach around the rib cage and I start to strengthen those. So I will do some shoulder retraction work, some shoulder blade work. Opening up the chest wall.
A bit of maybe resistance,
a little bit of band in there.
Yeah.
I will do some tummy work because I know there are abdominal muscles attach onto the bottom of the ribs.
Good. So
that'll be
gentle core work, not necessarily coming up into crunches
often
and
I'll
things.
go the other way. I'll do things like tabletop positions where I use the leg to work the core muscles.
Kind of more your Pilates-based exercises,
Exactly.
really.
So that you're not irritating the ribs while you're doing the exercises.
Not having to move. Yeah.
I will do a bit of arm work as well, because often when they load up their arms and it goes through the rib cage, they get pain. So little things like tricep dips, rows again, which are shoulder blades and shoulders. And I'll only pick a few of these depending on the patient, depending on how irritable their
Would you do a
symptoms.
bit of back work? Well, you're already doing back work with rows
I
and
do.
things, but maybe a bit of prone work if they can lie on their
if
tummy.
they can tolerate it. And what Ollie means there is exercises lying on your tummy, lifting the chest up if you can tolerate it,
lifting the shoulders,
or lifting the arms up. And then I do stretch the thoracic region, usually with hands overhead, side bending if they can tolerate it.
It's a tough one though,
it's a really tough. You're not alone. Like, we see these patients coming in time and time again, and flares up, settles down, flares up, and most patients are young. They do not want to be taking medication, and it is trying to manage what drives it. Because I would say in 90% of cases, when my costochondritis patients reappear, it's because they've decided they're cutting the entire hedge on one Saturday. So I go back to flare-up management strategies, the biggest one being pacing. So if you know there's activity that drives your pain, no more than 20 minutes of it. Try to manage the symptoms through flare-up management strategies.
Just taking breaks and breaking it up.
Yeah, taking breaks really, and planning the task so that you're not doing, I say, mix it up. Do a little bit of hedge cutting and then a little bit of wing, try to mix it up so that you're not working the same muscles all the time. So good flare-up management strategies is what I would go back to with these patients when they reappear, to try and avoid it again. Hopefully that helps, but it is a really frustrating one, costochondritis.
A few more questions, but what we might do is we'll get to them next week.
Same again,
I'm absolutely been eaten alive by midges. I'm not sure if you can actually see them here, but been eaten alive. So
thank you everyone that watched again. Hopefully that was helpful. So we had a little chat about bursitis, Ollie's getting stiff, labral tears. Then we talked about what can cause bilateral pins and needles in the legs, and then a little bit about costochondritis. So hopefully you find it helpful, and now we're off. Have a great Saturday night, everyone. Bye.
Take care.